Welcome to the third and final webinar of the Spring 2026 webinar series on the care and health workforce. I am Tiago Correia, and along with Ellen Kuhlman and Andrea, we are pleased to see you all today. This is an initiative that brings together the WHO Collaborating Center on Health Workforce Policy and Planning from the Institute of Hygiene and Tropical Medicine in Lisbon, with the journal Health Policy, the WHO Euro, the European Observatory on Health Systems and Policies, the European Public Health Association, and its section on health and care workforce, and also the WHO Collaborating Center for Public Health Leadership and Workforce Development. To all persons and institutions involved here, our big thank you for engaging with us. One last note to inform you that this session will be recorded for dissemination. In case you have any objection, you can always keep your camera off. I now pass the floor to Ellen Kuhlman just to continue. Thank you so much.
Thank you very much, Tiago. A warm welcome to everybody, also from my side. And I want to give you a very brief introduction of this webinar series. This is the last webinar in our series. And it is connected to a special issue of health policy. And what this webinar, why are we doing this? We want to provide an opportunity to especially connect the research with commentators and policy and practitioners. So as Tiago already mentioned, we have really a big group of supporting organizations that are connected. So this provides us a unique opportunity to connect these different perspectives that are all too often fragmented in the academic area. And this webinar focuses on transformative capacities, which I think is one of the most important and exciting issues to understand what is happening really bottom up, what opportunities are existing in the health workforce itself, and how can this be supported by health and care systems and policies. So how are we doing this? We will start with four brief comments related to research. Then we will have 3 commentators, and please, we have a Q&A that Tiago is moderating, so please use the chat. You will not have the opportunity to directly respond, but please use the chat. We will make sure that there is sufficient time for discussion. So therefore, I begin with introducing our first 4 panelists. That's Gabriela Lotta from Getulio Vargas Foundation in Sao Paulo in Brazil. Then we have Viola Bureau from Aarhus University in Denmark, Susanna Kotoreva from Charles University in Czechia, and Klaas Tek from the University of Twente in the Netherlands. And the same question to the 4 of you, based on your research, how can health and care workers transform health systems to build new capacities for a future workshop? So keep in mind, maximum 4 minutes. We go forward in that order that is in the program. Gabriela, please, the floor is yours. Thank you.
Thank you. Hello, everyone. Thank you, Ellen and Tiago, for organizing this webinar and for inviting me to be here. I will respond to Ellen's question based on a brief summary of the paper that we wrote together in many hands, including people who are also here in the webinar. And the paper is named Community Health Workers, a Comparative Assessment of Capacities of a Global Policy Approach in Selected European Health System. And what we try to do in this paper, trying to address also Ellen's question, is to examine the role of community health workers and community-centered health and care workers in different health systems in Europe, but based on previous experiences we had from South Africa and also from Brazil, where I am from. So we all know that globally, community health workers are increasingly recognized as an important strategy for strengthening the health systems. Research has shown that they can improve equity and access to care, They can strengthen health promotion, support vulnerable populations, and help connect fragmented health and social care systems. However, most of the existing evidence that we have in the literature comes from low and middle income countries, such as Brazil and South Africa, for example. And we have just some little research coming also from the US and the UK, but we still know relatively little about how these approaches of community health care are being developed in high-income European countries. And this gap is very important because the European health systems are currently facing multiple crises, including workforce shortages, aging populations, increasing inequalities, and fragmented system of care, which are actually some crises that we in the Global South have been experiencing over the last decades. So what the study tries to do is to connect the global debate on health, community health work with European experiences and ask the question, what transformative capacities do community-centered health and care workers have in different European health systems? What we did in this work was to conduct a qualitative comparative study involving 6 countries in Europe, so Denmark, Germany, the Netherlands, Portugal, Romania, and England, and also comparing them to the experiences that we had previously in Brazil and South Africa that were pioneers in community health work programs. And rather than only focusing on a traditional community health workers approach, which usually is what the literature does, we used a broader concept of community-centered health and care workers to capture a diversity in the occupational arrangements emerging in these different countries. So what our findings show by looking at Europe is that the countries are developing a very diverse pathways into community-centered care. Unlike Brazil and South Africa, where the community health workers are very strongly integrated into primary healthcare systems, the European approaches often go beyond primary care and create stronger connections between health systems, social care, and welfare systems. But we see these in different pathways in each country. So the first pathway that we found is the creation of a new occupational group, as happens, for example, in England and Romania. A second pathway is the development of multi-professional community-centered workforce, which is happening, for example, in the Netherlands and part in Germany. And finally, we found another pathway, which is the specialization of existing professions, especially nurses, as observed in Portugal. And across the countries, the most promising transformative capacities emerge when these workforce programs are connected to broader health systems reforms, community-based care, public health and strengthening, and social support services. So I think that one of the main lessons here is that it's not only about contracting community health workers to do something new, but to integrate these kind of services, even by using workforce that already exists in the country, but most of all connecting them with the whole healthcare system focused on community healthcare. So what we saw based on this idea in the countries is that currently no country is using this whole capacity fully or effectively, and major barriers include still fragmented governance, insufficient funding, weak regulations, and limited professional support. So in conclusions, I think that based on the study we conducted, we can bring some discussions here to the table. The first is the importance of adding more experience about the European countries to understand how these community approaches are being developed in high-income countries. The second is to strengthen this communication between South and North experiences for our policy learning. And third is to argue that community-centered health and care workers should not be understood only as an occupational category, but as part of a broader effort to transform health system and strengthen community-centered care. Thank you very much. This is just my first presenting, and we can come back for further discussion.
Yeah, Viola, do you continue, please?
Thank you. I think I will continue with a case again, where there's sort of dormant transformative capacity. Our study is based on the primary healthcare workforce in Denmark, in many ways a small country, but I think the implications are relevant for a broader range of countries. So the transformative capacity consists of the primary healthcare workforce supporting both policy making and implementation, and particularly by being involved in policy making and in reform making early on. When we look at research on the primary healthcare workforce, it's often concerned with funding, with organization, and with different roles. And where the primary healthcare workforce in many ways appear as sort of policy implementers. And in many ways, we argue that because of their very detailed, in-depth organizational knowledge, they should be included in policy making sort of early on. And that is because they have distinct ideas about what the workforce is, how it should be organized, and what kind of practice models there should be. And that has implications about for the acceptability of reforms and so on. So what we specifically do is that we look at narratives. We look at different ways of defining problems, assigning responsibility, and legitimizing solutions. We all know about the sort of idea of primary healthcare from the Alma Ata Declaration. However, what we found in the case of Denmark, and you might recognize that from other countries, we found three very different narratives about primary healthcare. One was a health economics narrative, which prioritizes central planning and believes in task shifting to improve cost effectiveness. The second narrative was a medical narrative, suggesting that general practitioners as gatekeepers should be the driving force and that they are the backbone of medical quality. And thirdly, a community narrative, which sees primary healthcare as decentralized, local person-centered, and sort of driven by local authorities. And these different narratives, they are not just words, they are not just discourse, but they matter for governance, what one considers to be good governance. They matter for task shifting. What does one consider to be a good workforce? And they matter for models of service, who are the sort of recipients of primary care. So in conclusion, I think what reforms and policies need to do, they need to acknowledge those different views of primary healthcare and navigate between those sort of different narratives, because otherwise reforms are in danger of increasing the tensions in primary healthcare. However, this is a tall order because narratives, they are context sensitive, and different health workers use them strategically. So in a way, we probably need to sort of rethink policy making as a way of sense making. So three take-home messages: identify the narratives, formulate policies which speak to those narratives, and support collective sense making. Thank you.
Thank you very much. Susanna, please. Susanna?
Thank you. Thank you very much. So in responding to Ellen's question, our research shows one quite simple thing, and that is health and care workers can transform health systems by making visible capacities that already exist in practice, but are fragmented, under-supported, or outside formal workforce governance. In our research, this became visible through three groups of workers involved in the Czech response to the arrival of Ukrainian refugees. First, frontline health workers, so-called intercultural care workers, and Ukrainian health professionals. First, the frontline health workers. These were GPs, nurses, emergency staff, who had clinical expertise and formal responsibility to provide care to Ukrainian refugees. But they often had to provide this care in a very difficult conditions without sufficient tools or support. So they adapted. They worked more. They created practical solutions. They tried to help each other. In short, they tried to keep care going. And this helped the system function, but it also showed how much the system relied on their individual commitment and improvisation. The second group were so-called intercultural care workers. These are often workers with migrant or refugee backgrounds connected to NGOs, municipalities, communities. Their role is to help with interpretation, cultural mediation, and navigation of the health system. And in our research, they helped the Ukrainian patients and the Czech healthcare professionals to understand each other. So in many situations, care would have been very difficult and sometimes almost impossible, I would say, without them. But they are not recognized as a part of workforce. Their role is not clearly defined in the legislation. Their work and also funding are often project-based, so temporary, and they have also limited training, supervision, long-term support. The third group were the Ukrainian health professionals who had the clinical knowledge as the first group, the language skills and the cultural understanding as the second group. So in this sense, they could have bridged the gap between the formal clinical care and culturally sensitive communication. But in practice, their potential was underused because the qualification recognition process is very lengthy and administrative demanding. So in conclusion, the key lesson is that capacity building does not always mean creating something new or simply add more workers. Health and care workers can transform health system by showing where our understanding of the workforce is too narrow and how existing but fragmented forms of expertise can be better connected into a more resilient future workforce. Thank you very much.
Thank you. And Klaas, please.
Yeah, thank you, Ellen. I'm taking you to another perspective. My name is Klaas Stek. I'm working in purchasing and supply management, and our health policy article was entitled Strengthening Innovation Capacity in Health and Care Workforce, a role-based framework for procurement professionals. So we are focusing on purchasing and supply management in the health and care sector. We are addressing Europe's pressing demographic challenges. I must underline here aging populations, raising multimorbidity do skyrocket the demand, and the working age population, including health and care professionals, is shrinking. We know that all. The only way out is to increase labor productivity, and the fastest way to increase labor productivity is through innovations. But here's the catch. Innovations come from outside mostly, from suppliers, from unfamiliar value change, even from startups. And without procurement as a bridge between the internal world of health and care and the external world of innovation, these solutions will never reach patients. Yet, procurement in health and care is unprepared. It's traditionally operational and transactional, dictated by clinicians, focused on cost and compliance, and is one-sided, focused on exploitation. Demographic and technological pressures demand a shift. Procurement also needs exploration to sense external innovations. These procurement persons need, this procurement function needs bridge builders who understand internal needs and can detect, engage, and connect with innovative suppliers to turn external innovation into internal impact. In our Horizon Europe project, and support that's underlying this article, we uncovered 6 emerging roles, not functions, roles that you can fulfill within in a function that redefine procurement as a catalyst for innovation. First, we detected a strategic business partner that aligns procurement with clinical and strategic goals. The innovation matchmaker scouts and co-develops solutions with suppliers before tenders. The digital automation expert leverages data and AI systems to streamline processes. The sustainability coordinator embeds environmental and social criteria into contracts. The data engineer turns procurement data in actionable insights, and the innovation coordinator scales solutions across the system. The common ground for these roles form a framework that transforms procurement from an exploitative back office function into an explorative strategic engine for innovation, powered by the dynamic capabilities, sensing, seizing, and transforming. For policymakers, the message is clear: rethink procurement in health and care. Professionalize these roles. In our study, we extended the European Commission's ProcureComp EU public procurement competency framework for role-based sector-specific competencies for health and care. The second point we emphasize for policymakers is create enabling conditions, flexible tenders, cross-functional teams, and leaderships that rewards innovation. Because the future of health and care depends on connecting internal needs with external innovation, the message is invest in bridge builders. Thank you, Ellen.
Thank you very much. I think, thank you to all 4 of you, and I think you gave us a very great broad perspective on what kind of innovations are available. And I just want to add to this 3 more papers, just briefly, as we had in our special issue much more papers than we could accommodate. And one is on transformational leadership in PhD programs from Barbara Löfland-Birkin. Another one, really very important and interesting, on nurse-led models of care for refugees. There are connections to Susanna a bit from Andreas Gold. And lastly, I would like to mention a paper from Laura Kielström, always with collaborators, on individual health and care experience of health reform, which goes a bit in Viola's direction. So you find the links of these papers and also of the other papers and our editorial all in the chat, thanks to Tiago. And now we are moving on. I'm not trying to summarize that as we don't have time. I would like to go over to our 3 commentators. And here I must announce a slight change. So we have a change to the program, but we still have 3 great commentators. We come back to Gabriela Lotta, who you know, and she will have a double role now, as she is also an international expert in frontline healthcare workers, street-level bureaucracy, and especially related to capacities in vulnerable and politically unstable settings. Then we have Olga Gershuni, who is from Maastricht University in the Netherlands and also teaches in Kiev, in the Ukraine. And third, we have Marius Ungureanu, who is the president of the European Public Health section on health and care workforce research. And to the 3 of you, I have the same questions. So based on your experience, how can we use the transformative capacity of health and care workers most effectively? So just 3 minutes commentary and we move on in the order. Gabriela, it's again you, please.
Thank you, Ellen, for this new role. So I will just make a brief comment based on both the Brazilian experience using a more street-level bureaucracy approach, but I also would like to make comments based on the presentations of my colleagues, these former presentations. So I will start with something that Viola just mentioned, that usually when we think about frontline workers or street-level bureaucrats or health workers, they are usually seen as implementers who receive a mission and have to implement them, as if it's possible to just somehow formulate and think about all the possibilities that frontline workers will find when they go on the ground and interact with patients. But we know that actually, especially when we are talking about contexts that are very heterogeneous, multicultural societies, vulnerable places, and so on, that what happens on the ground is usually not predictable. So it's very hard for the systems to design something that can be implemented as it was designed, just because context matters and the interactions change what happens on the ground. So it's very important that the transformative capacity have this in mind in order to change the way we think about policies and the policy decision-making process. And I think that Viola discussed this very well. So the idea is that we have a lot of knowledge going on the ground, as Susanna also mentioned, and this knowledge is usually lost because the system does not create forms of feedbacks in which the policymakers learn from what is going on the ground, and we just leave people making decisions there, and we don't learn based on the experiences and the innovations that they create by interacting with real citizens on the ground. So I think that we should be able to change our systems, and this is the transformative capacity I can see when I look at the Brazilian context, in which we can learn from the ground, support local innovation, exploration, and experimentation, as Klaas just mentioned, but at the same time learn from it, include frontline workers in policy decision-making, creating upwards and downwards dynamics that enable a more coherent policy implementation based on principles, but also based on knowledge that comes from the ground. In this way, we should, as Viola mentioned, rethink policy making as a way to sense making, have more communitarian and territorial approaches, because this links us to the ground level. And just to finish, as Susanna mentioned it perfectly, not creating necessarily something new, but actually connecting what we have so far that is totally disconnected. Because again, I want just to reinforce this, there's a lot of knowledge being made on the ground. There's a lot of nice innovations being made based on the discretion that health workers have when they are interacting with patients. And this knowledge is lost in the system when we don't create systems of feedback and learning from the ground in upwards and downward processes. So I think that the transformative capacities should come from this way of rethinking the systems, making a better connection from the ground to the top level of decision making. Thank you.
Thank you very much. And we move on with Olga, please.
Thank you very much. I hope I'm audible. And I would like to briefly discuss the transformative capacities with the example of Ukraine. So, of course, the Ukraine health and Ukrainian public health workforce is operating under a very difficult and challenging conditions. And there is no training that can fully prepare you for that. So, and still the transformation is happening, not despite the war, but kind of in the middle of it, which is a very interesting subject. So the statement or the commentary I would like to address today is that there is no question that the workforce roles are changing. They clearly are. But the question is whether and how can we capture and invest in that changing capacity. So there are many examples, for example, in the workforce role transformation. And I'm going to take you to my professional background, which is nursing. So nurses are taking now much broader clinical and coordination responsibilities. And if we talk about public health specialists, they are now stepping into humanitarian coordination, but also sometimes in the surveillance of the crisis. So also another quite interesting component is rehabilitation and mental health profession. So rehabilitation and also prosthetics, unfortunately, happening very often in Ukraine. So that's also become an everyday health issue. So regardless whether you are working in that field, you would see people with the prosthetics from the military to young children. So healthcare should be addressing that issue, and clearly the workforce is not really prepared for that. Also, the combat medicine is also have spread into the civilian practice. Environmental or animal health issues also poses a lot of challenges, and they completely transforming healthcare delivery just as we go. So that says a lot about this adaptive service delivery capacity of the workforce. We could also take the perspective of digital capacities, which are very important and highly used. So the electronic health records, but also even WhatsApp communication to providing telehealth consultations are really often used. So despite displacement or attacks, they are functioning. Maybe also something important to mention is the psychological resilience capacity. I mean, there is things such as peer support, moral commitment also to deliver the services under those extreme pressure conditions. And those things are not small. So those capacity building blocks are really transforming the health system. And we have to use those building blocks to contribute to that. And of course, there are structural threats that we can't ignore, such as the substantial outflow of health professionals or even relocating of health professionals to the front line. So this high turnover means also a lot of knowledge loss. And that also means that the qualified personnel would, even after the war, it won't be resolved by itself. So we must really thinking towards the careful decision making when we would involve also all stakeholders. Maybe last thing I would like to mention: it doesn't matter whether there is war or peace. Still, the services have to operate under the laws and regulations. And the credentialing and licensure are still very crucial, and they would support the workforce and the services they deliver. So the Ukrainian example is that even under the war condition in 2022, the law on public health system was adopted. So although it's yet not completely unpacked for the workforce personnel, it is a document which is operationalized, and it's also clearly outlines the system. And so I think just to conclude, the workforce transformation in Ukraine nowadays is already a form of innovation. So, and of course, the transformation cannot wait for the peace because it's happening right now. So on the other hand, on the good note, war does not only destroys the health system capacity, it also forces for the improvisation. So this is a good thing that's and gives also the possibility to see whether there is some parts in the system that are authentic and also resilient. Thank you.
Thank you. Marius, please.
Thank you, Ellen. Hello, dear colleagues. In my intervention, I want to focus on a dimension that cuts across pretty much everything that we've heard today, and that is health and care workforce migration, and present my arguments for which this is not just a crisis symptom, but this is more like a potent transformational lever. Because what we are seeing nowadays in Europe, we are seeing a paradox in the sense that we have, on the one hand, health and care systems which are under strain from workforce shortages, but at the same time, we see thousands and thousands of international educated health professionals including, as Susanna highlighted, Ukrainian refugees who are either underemployed or facing systematic barriers to their not only to their recognition but also to their integration. So I believe that the transformational capacity here is pretty much largely untapped, and because these workers bring a wealth of clinical skills, they bring resilience, they bring adaptability, and oftentimes because they work in resource-constrained settings, this makes them relevant to the challenges that our European health and care systems are facing. However, we see that we are failing to mobilize them effectively. So in my view, there are at least three things that need to change. First of all, I was mentioning about recognition and integration, and I believe that we need a more harmonized and a lot more flexible framework, because currently what we have in the European Union is quite a patchwork around or among member states, and this is really a structural barrier that impedes transformation. Second, integration must move beyond licensure, because it should include mentoring, it should include language support, it should include also introduction into cultural norms, and a pathway into a system that retains health professionals' dignity and that builds on their competencies. And third, we need to reframe migration. And this is something that we've talked about extensively, including in papers with many of you here, arguing for the fact that migration for such a long time has been looked at either as a loss for the origin countries, or as a windfall for destination countries. But really, we should look at it as a significant governance challenge, a challenge where we need bilateral discussion, and we need EU-level frameworks that can create a more equitable systems and outcomes, because we know this is not the case currently. So to sum up, I believe that the research that was presented today shows us what's possible when systems create the conditions, and as discussed so many times when we meet, I believe we really need a secret ingredient, which is political will, in order to move from the evidence to the results. Over to you, Alan.
Thank you very much, especially for two things: for keeping time, that gives us the opportunity to discuss, but most importantly, also for giving us so many concrete examples, I think. So we have a very broad range, and I hand over to Tiago to see what's in the chat.
Actually, Alan, our chat today is quite silent. I don't know what does this mean. Eventually, the presentations and the comments were so straightforward that there is no doubts, questions. But anyway, I will invite anyone who would like to pose any questions or to comment what has been said, and to have people from Africa, from the Palestine, from many other places, the US, and so on. So this is fantastic. But while I'm waiting to collect some questions or comments from our audience, I will ask our participants. Particularly, I have a couple of questions just to warm up to our presenters. For instance, Gabriela, could you please expand a bit about what Europe can learn from Brazil and South Africa about community healthcare workers? So what is the key learning for the European health systems? To Viola, my question would be, what capacities are needed in primary healthcare beyond simply having more workers? So what does this mean, having more capacities in the primary healthcare? To Susanna, I think it's very important to understand what the Czech example might mean in terms of workforce preparedness And this is very important. So what does this mean in terms of preparedness? And also to Klaas, he mentioned about professionalizing procurement roles. Could you please expand a bit more about this? Gabriela?
Yeah, should we follow the order? This was the question. So thank you, Thiago, for this nice question. I will have to be very brief here because I could talk about many things based on our experience with Brazilian community health workers. But I think that there are two lessons from the Brazilian case that maybe we can think about how to reproduce. The first one is, I don't know how much people know about the case, but the community health workers, they were created here in Brazil many decades ago based on the idea of having people who lives in the territory and they have good connections with the neighbors, with the people from the same community. And then they are asked, they become bureaucrats, they become health workers to visit people in their houses. In this way, we have a kind of workforce, health workforce, who daily visit houses and make a good connection between the families, the community, communitarian dynamics, and the health system. This is the first important lesson, I think, because they are able to make things like translation of knowledge. They have different types of, like, they know the tricks about how to engage people in making treatments, how to make people comply to the services, but at the same time, they can bring information, very important information, from the houses to the system. And this connection only happens because these people live in the community where they work. And I think that this is a very important lesson, is the idea of creating really a communitarian primary health approach. The second lesson is that at the same time that they are very connected to the community and they are like the open door of the whole system, they belong to a health team. So they have the support of a physician, of a nurse, and a whole team in the clinic that professionalize them, that teaches them how to understand the information they collect, and also help them delivering a better service. So they are not alone. And this is something that happened in the past in Brazil and happens in many countries of Africa, that community health workers are alone. But in Brazil, we learned the lesson that they have to be connected to a team and they have to be connected to a health clinic that is the main reference of the primary health care in the territory. So I think that these are two very important lessons here. They are not an occupation that works alone. And the second one is that they have good connections with the community.
Thank you so much. Viola, can you please?
I think I could just continue on from Gabriela. We simply need a greater diversity of the primary healthcare workforce. In many ways, Denmark is a sort of critical case. It's a highly decentralized health system, with strong public authorities, at the local level. Yet what we are seeing is a highly sort of medicalized idea of primary health care, where task shifting is embedded in, delegation. So I think a much greater diversity of care workers, which, as Gabriela illustrated with the community health workers, also can connect to people, connect to communities in very different ways. Thank you.
Thank you so much. Very clear. Susanna?
Yes. Thank you very much. So for the preparedness, in my opinion, the Czech case suggests that preparedness should be understand less as a fixed emergency plan and more as a capacity to recognize and also mobilize the right forms of expertise when pressure comes. So in my opinion, the crisis showed that the system did not only need more like clinical capacity, but it also needed communication, navigation, cultural sensitive understanding, emotional support. And these capacities existed, but they were fragmented and not really recognized. So preparedness means, like as Gabriela already mentioned, learning from what workers develop in practice. Preparedness is not only about being ready to react, but it's also about building workforce system that already knows where the hidden capacities are, and show ways how to connect them.
Very clear as well. Thank you, Susanna. And Klaas, what does professionalization of procurement mean?
Yeah, I was thinking about expanding it also to the broader role. There's always a discussion: is procurement limited to the procurement department, or is it also including the nurses, physicians, etc.? I think the latter, and I think if we can include the roles we found, for instance, I have here the data engineer. I heard Gabriela talking about first-line workers need feedback. Data could be feedback. So if you have a good data engineer that can turn data into an actionable insights, they have already something. What I emphasized is the difference between old-fashioned, and it's not a bad thing, exploitation, keeping the business running, and exploration, how you do your business in 2 years or 5 years, or let's say in the near future. So there's a difference between exploitation and exploration, and the tendency is to be more on the exploitation side, the daily jobs, etc. And underlying in every presentation, there's a risk averseness, I think. In normal situations, we are risk averse, except when we see a war in Ukraine, for instance. Then there is time to reach out and do experiments, and that would be a positive side at that dark page in the history of Ukraine. And I think what Olga mentioned, and it's another study of mine, resilience is one of the most important parts to focus on for your workforce, because we know that resilience is empowering creativity, and creativity is needed for innovative power. For that side, the exploration sides, and these 6 roles that I was mentioning are all explorative roles, looking outside, communicating, and instead of sitting and doing your job, your daily job, and doing the exploitative thing inside. Let's rethink the systems, and let's rethink the systems with diversity. I agree with Viola, and then we come to more resilient health and care systems, I think.
Thank you so much, Klaas. Now I will grab your words, and to looking at the chat, Alan just put it a question actually. So the thing is now how to address these capacities in terms of the health systems, and how to have health systems thinking about these new capacities, how to closely integrate these capacities in the governance architecture. Eventually, I will now ask our commentators to step in. A very brief answer. How do you see the ability and capacity of the health system to integrate these new capacities in terms of the governance structure? How would you approach this important challenge? Olga, Marius?
I can try to start. Yeah. Thank you very much for the question. And yes, indeed, I guess also, as I already mentioned, there is a lot of transformation nowadays in Ukrainian health and public health capacity, and that's already an innovation itself. And there is a lot of going on, but that's also important to understand that every system needs to be supportive and reflective into the needs and burdens of health and public health workforce. in order to recognize and support them appropriately. Because if there is a transition in the healthcare system already, it means also that presses additional burdens on its execution, because it has to be introduced, it has to be unpacked, but it also has to be explained to people who are delivering those services. Thank you.
Thank you so much. Marius, would you like to add something?
Yes, I will just follow up on my initial comment about health and care workforce migration, and what maybe this is not something that is an action point, but I believe what is relevant, what I see relevant is in this point is a paradigm shift, as looking at health and care workforce migration as an innovation priority and not just simply something that is marginal. Because I believe that if we invest in these equitable integration pathways that I mentioned, I believe that we will not just gain numbers in our health and care systems, but we gain a lot in terms of diversity, in terms of equity, and in terms of resilience and adaptability in the end. And so, as I previously mentioned, I believe that we really need to understand the fact that we have the tools, and what we are lacking, among others, is political commitment. And at the European Union level, I believe we really lack coordination. I believe that we should overcome the standard language that which stems from reality, the fact that health is a mandate of the national member states, but there's a lot that EU can do in terms of convening, in terms of coordinating to make this a reality. Over to you, Tiago.
Thank you so much, Marius. Thank you so much, and the comments were very clear as well. I will now pass the word to Alan. Alan.
Thank you. So I think that was really very exciting, especially also your comments, and it reminds me in a way our last part of the discussion on where we started in webinar 1 on the planning, where it was a very strong point. Also, we need institutionalization. We need to integrate these data into a governance structure. So to come from these technical procedures really to change in the system. And in a way, our debate now reminds me on this, although it goes in a different direction. But I think you brought so important issues that show there is innovation capacity, there is transformative capacity, but currently it is totally fragmented, scattered here and there. And there is no way, as Marius said, coordination is missing. Coordination is missing, and also often a level below, institutionalization is missing. Often, especially from lower level, lower status professional or healthcare workers group like community healthcare workers, often this capacity does not come up high enough to the policy level, does not make it into institutional change. And then there is always a big problem that it get lost. If something in the system changes, if the environment changes, it's lost. If it's not institutionalized, if it's not part of the governance issue, it's very often not sustainable. So I think it would be very worse to continue this debate and really think, what can we do to develop structures that really integrate in the governance structure these capacities? And there is a model from the health professions that does not fit perfectly, but I think it might be worth to think of this, that is these self-governance capacities of professional groups, which have problems, as we know, as it creates silos. It might be worth to think in a way, how can we use these self-governance capacities, the street-level bureaucracy, the innovation theory, the resilience theory, how can we bring these together and then think, what can be done really to strategically bring that into systems and improve coordination? finally, I want to give the word to our three commentators, challenging you even more than we did the whole time. I think so. In 1 minute, what is your key message? What should we do in future really to improve the system and use these capacities? And I suggest we move on in the same order. Gabriela, Olga, and Marius, please.
Okay, so I think that one of the main things that we should learn here is about how to create new arrangements and instruments that can do what all of us have been talking about, these upwards and downwards connections between what is being decided and what is being implemented, not only to guarantee that the decision will be implemented, but also to learn from implementation. And in this way, create instruments that can give us more coherence in the system. I think we lack, when we talk about the lack of coordination, is also a lack of coherence. Each person is doing one different thing on the ground because they are just surviving. And we rely on the resilience they have by themselves and the innovation and the creativity they have. But actually, we should coordinate a process to have coherence and learn from them what can be replicated and redesign the system. So that's, for me, the main lesson. And this process should be institutionalized, as you mentioned, Ellen.
Thank you. Olga?
Thank you. Yes, and maybe to add on that, I think also the workforce role transformation has to be taken into the consideration as something which is going to stay, because that's already transformative. So when the professionals take a broader roles and responsibilities, it should be considered. So, for example, even when there is, let's just say, the educational system can be complex, it can be robust, but still quite complex. It has to be also simplified somehow. So it's not adding extra. It's also understanding that maybe less would be also sufficient, especially when there is a question to work under the pressure. So the workforce transformation as a capacity, and also the integration of the different roles and perspective within existing workforce should be definitely an added value, and also should be taken while institutionalizing the healthcare delivery. Thank you.
Thank you. Marius?
Thank you, Ellen. I would have so many to say, but I will pick on something that Gabriela mentioned. So she mentioned about coordination, which needs cohesion, and I will say something which starts with C as well, and that is community. That is not maybe on the content, but it focuses on the process, because we know each other, we know each other's work, but still we are frustrated by the fact that not much is happening. And so I believe we need to act more like a community. There's some very nice work on epistemic communities. We need to see ourselves more like communities, like a community, and try to push for change from every direction, because each one of us has a particular focus, a particular capacity and skills, and we should act more like a community and push for change, because we need change. Over to you, Ellen.
Thank you very much to all of our speakers, to our participants, and especially a big thank you, as also for the two other webinars, to Tiago, Andre, and the whole team from Lisbon to make this possible. So I hope you enjoyed this and found it useful. Thank you very much. Tiago, the final word to you.
Thank you. Thank you so much, Ellen. Thank you so much, everyone. To all our speakers, obviously, to our commentators, to all partners and participants. This final webinar made clear that we are facing a poly crisis, but also that there is a space for innovation and a space to creativity, transformation, and system innovation. So I would say across the three webinars, we have tried to create a space where research evidence, policy experience, and institutional perspectives could speak to one another. Obviously, I want to thank Alan, Andrea, and all colleagues involved in this series, as well as the Institute of Hygiene and Tropical Medicine in Lisbon, the journal Health Policy, WHO, Europe, the European Observatory, EUPHA, and all the collaborating institutions that made this possible. A special thank you to all authors who contributed to the special issue, which give us a strong basis to continue this discussion beyond today. For your information, I will now paste in the chat the links to the recording of the previous sessions in case you want to follow us and to follow what happened, and this one will be made available as well. So please stay tuned, and we will for sure continue all these discussions. Thank you so much for your attention. Bye. Take care.
Bye-bye.
Bye bye. Take care.